I'm sure all of us, including our patients too, have experienced a lot of bothersome and long-standing bouts of acute cough. So, what could be the probable cause? How to diagnose and differentiate between infectious and non-infectious etiology? To know more about it, we have with us one very eminent and internationally renowned personality, Dr. Vikram Jaggi, who would be taking us through the topic on infectious versus non-infectious acute cough case-based key differentiators. Welcome, sir. Thank you so much for accepting our invitation, and it's my honor and pleasure to introduce Dr. Jaggi, sir, briefly. Dr. Vikram Jaggi, sir, is a medical consultant pulmonologist and medical director at Asthma, Chest and Allergy Center, Delhi. He holds a double gold medalist from Maulana Azad Medical College. He has authored more than 15 books on asthma and allergy. He has contributed to several chapters, namely allergen immunotherapy in the textbook of pulmonary and critical care medicine. He has maintained several educational websites. He's also authored many articles for several newspapers in India. He's delivered more than 300 lectures and chaired more than 60 sessions both in India and internationally on asthma and allergy. He has very recently published a book on cough, which is called as Coughology, the art and science of navigating cough, which is a first of its kind, giving a broad overview about cough and its management. I think it's a pleasure and privilege to have you with us, and it's my honor to share this virtual platform with you, sir. And now, without much wasting time, I would like to hand it over to Dr. Vikram Jaggi, sir. Over to you, sir. Thank you so much.
Thank you so much, Dr. Jay. So let's dive deep into it immediately. Let me start by sharing my slides. Yeah. Slides are visible. Friends from all across the world. I'm told that doctors have joined from Africa and Myanmar and so many other countries. So today we are talking about an important subject, which is cough. And we'll be talking a little bit about the clinical approach. Dr. Indu will be talking about cough from the pediatric point of view, which is very important. Then we'll have a panel discussion. And then we'll keep time for you doctors to send us questions, which we will be very happy to take. Okay. So this is a little bit about me. I work with asthma and allergy for the last 30 years. This is the book that Dr. Savai was talking about. I think it's a easy to understand book, and anybody who's interested can get in touch. I'll be happy to send a PDF to them. So let me just start with some very general comments about cough. When patients come to the doctor, the two most common and important problems they come to the doctor with are cough and fever. Either cough or fever or both. Cough is clearly the most common symptom for which the patient approaches a doctor. It is my strong feeling that in the last 5 or 10 years, we are seeing much more of cough in general than what we were seeing before. Cough is more common. It is occurring more frequently. It is taking more time to sort of get okay. The medication that we used to give and we were confident that the cough will become all right, it's not working. What are the reasons? To my mind, the reasons are our general poor health because of our poor living habits, our modern way of living, the increase in allergic tendencies, which is happening all across, and the pollution is playing a big role over here. Cough, I think, concerns all specialities of doctors, whether they are GPs, whether they are respiratory specialists, internal medicine, ENT, pediatrics. So it concerns everybody. And we also know that symptomatic treatment alone of cough is not that effective. We really have to get to the diagnosis. What is behind that cough? Cough is a symptom. What is causing that cough is important, and that diagnosis is sometimes not easy. A systematic approach is required and an anatomical approach is required. Also becomes important to rule out dangerous diseases or the red flags, etc. The problem is further compounded by the fact that the cough is of multifactorial origin in a given patient. And hence it takes time, and the doctor and the patient's family, they need to be patient. So what is cough? Cough, we all understand, is a protective mechanism of nature, which when something either we inhale, which our body doesn't like, or we aspirate something which body doesn't like, or something drips down the back of our throat, which the body doesn't like, the body tries to cough it up. So these are the three main things which drive cough. It's a reflex. Another way of looking at cough would be normal cough as a symptom of a disease and as a disease in itself. What do I mean? Normal cough. We all cough a little bit. In the morning, we cough to just clear our secretions. If we enter a room which has got a strong perfume or something, we cough. That's normal. It doesn't bother us. 10 to 15 coughs in a day is normal. It can be a symptom of a disease. Then we have to sort of sit and understand whether this cough is serving a useful purpose or is it totally useless and it is driving the patient into despair. The first one we need not suppress, and the second one we can suppress. Sometimes the cough is so troublesome, it is not serving any purpose. It's a dry, hacking, non-stop cough. There are certain diseases. Then the cough becomes a disease itself. So cough poses problems for patients as well as for doctors. For patients, the problem is social embarrassment. They are shunned actually, because there is a fear that they are spreading infection, and this has become especially important after COVID. It's a big annoyance. They get pain in the chest. Females after a certain age, more than 40, 45, if they have bad cough, almost invariably they lose control on their bladder and the urine leaks out, which is extremely embarrassing. They have to wear pads. This is a delicate issue. Unless you ask, nobody is going to tell you, but gently, carefully, delicately ask about it. Males, when they have cough, they have a syncope. They kind of faint. They are driving, they are coughing, they may have a major accident. Some people have such long coughs that they go into depressions. The problem for doctors are slightly different. You see, the cough seems to be a simple problem, but oftentimes the diagnosis is not easy. You really have to apply your mind. There are multiple reasons. You give the treatment, the patient expects that the cough should get okay by syrups and things, but it takes time. So we have to be patient. And also, when the cough is there and we really don't know what's the reason, always a little bit fear is there in the patient, in the family, and also in the mind of the doctor. Is there a serious problem behind it, which I'm missing? How much to investigate? You unnecessarily investigate, you increase the cost for the patient. You don't investigate, you may risk missing something. So these are some dilemmas which doctors will face when they are trying to diagnose cough. So whenever we are faced with a patient of cough, it is a good idea to sort of just categorize whether it is acute, subacute, or chronic. This is not a theoretical thing. It's a very practical thing. Less than 3 weeks acute, between 3 and 8 subacute and chronic. The causes are quite different. Today, the focus will be largely on acute coughs, so I will stick to that mainly. What are the common causes of cough that we face? We all know this. Respiratory tract infections are the major reason which make patients cough and they come to the doctor. There is an entity called post-infectious cough, which is very stubborn, nagging. I'll just discuss a little bit about these two. Then, of course, anything which can cause prolonged cough can also present acutely. So cough variant asthma, gastroesophageal reflux, upper airway cough syndrome, these three, third, fourth, and fifth, are in fact the commonest cause of undiagnosed cough, where the patient is coughing, there is no clue, X-ray is normal, he's not a smoker, and he doesn't take ACE inhibitors. You should always think about these three things, and most often you will get the right answer. ACE inhibitors, we know, induce cough, and there are some other reasons. I will discuss the first two a little bit, digging deeply, not too deeply. And if there is time is short, I may go into the other ones also. So the approach is, as of any medical disorder, history, exam, and investigation. If I was asked to choose only one of them, the doctor, you can only take a history, or you can do a physical examination, or you can do some tests. Without any doubt, I will take a good history. That most often tells us how did it start, the cough, how did it pan out, what made it better, what made it worse, what was the diurnal variation, what was the seasonal variation, did it come back, which treatment helped. These are the things which help us much more than exam, or even, I would go on to say, investigations. So, respiratory tract infections. So, respiratory tract infections are largely viral infections. We know that 90% of the time they are viral. They come with fever, malaise, headache, sore throat. We understand that this is a viral. Many times we still end up giving patients antibiotics. It is my request that this should be resisted. Sometimes the patients pressurize us. I am feeling very unwell. I have very high fever. I have too much pain in my throat. Fine. Even a virus can cause too much pain in the throat. Determine confidently whether it's a viral or a bacterial. If it's a viral, do not give antibiotics. If you think it's a bacterial infection, then try to find out which bacteria, which antibiotic is likely to work, and only then give antibiotics. So upper respiratory infections, lower respiratory infections, largely viral. We understand what a viral prodrome and syndrome is. And if we are sure, and the counts are normal, and the phlegm is not yellow, and the fever has also gone down, do not give antibiotics just because the patient is coughing or pestering you to give antibiotics. Post-infection cough. Now, this is also an important thing. That what is this? There is a viral infection. The fever has gone. The cough has actually increased. And the cough goes on and on and on. And to my mind, three things are important here. The virus denudes the inner lining of the air tubes, making it sort of very vulnerable, and the patient coughs. These patients who have very prolonged post-infectious cough are usually atopic. They have a personal or a family history of allergy, which means their underlying airways are, as it is, a little oversensitive, and the environment with the pollution obviously adds to the problem. So these combined three things have made post-infection cough nowadays an extremely common thing, that after a virus, we doctors don't have the confidence to tell patients that, look, your cough is a virus, it is virus-induced, and it will automatically get okay in 7-10 days. Oftentimes, it does not. So the four defining features of post-infection cough are, it's caused by a virus, it generally lasts from 3 to 8 weeks, that's up to 2 months. Number 3, it will get okay on its own, and the X-ray is normal. I have about 3-4 minutes, so I will cover some other topics and then finish. Cough variant asthma can present as cough, and it has all the other features of asthma, but the patient is not having too much of shortness of breath. So here we have to carefully look into the lung functions, maybe do some provocation, maybe give a trial of inhaled corticosteroids, etc. We can discuss these things a little more detail in the question and answer. Gastroesophageal reflux is a common cause of cough. The clue is that the patient starts coughing when he or she lies down. When he or she lies down, cough starts and he or she has to sit up. Of course, there are other clues also. Upper airway cough syndrome is what we used to call postnasal drip. So anything which is happening in the upper airways, sinuses, and causing dripping of secretions, initiating cough or causing cough is nowadays called upper airway cough syndrome. This is also an important entity. Anything which blood pressure medicines which ends with pril, enalapril, captopril, lisinopril, it's very, very commonly it can cause cough in people. So they start the blood pressure medication. 2-3 days later, 2-3 weeks later, they start coughing, dry, irritating cough. So when you're faced with a patient of cough, always ask about this. This, I think Dr. Indu is going to take. I have an idea that she is, so I'll skip it. And this also I'll skip for the moment. So I have finished about 2 minutes in advance. And so this was just a very broad overview of